Good evening, everybody. As always, it's a to be a part of Year in Review Breast Cancer. Today, I'll be discussing 8 abstracts on ER positive early breast cancer. As we all know, we have options of hormone therapy in early breast cancer, but the gray zone area of whether or not to give chemotherapy is haunting all of us always, unless we have access to genomic assays, and even after that sometimes we don't have all the answers. So the first abstract is on MINDAC trial. So in Lancet Oncology, this last March, 8-year updated analysis by age was published. And as we all know, MINDAC trial had T1, T2, T3 operable and N1 up to N1 patients, and these patients were then classified based on their clinical and genomic risking. Clinical was as per adjuvant online, genomic was as per MammaPrint, and the discordant groups were randomized to receive chemotherapy versus not receive chemotherapy. And it was a positive de-escalation trial, because the clinical high, genomic low patients showed excellent disease metastasis free survival of 94.7%. Now, this updated results at 8.7 years, where more than 90% of patients have finished 5-year follow-up. The results continue to be good, in fact, better. So now the updated disease metastasis free survival is 95.1%. And when they were classified based on age, as expected, the benefit of chemotherapy was seen in patients less than 50 years of age. So distance metastasis free survival, there was an absolute difference of 5% in patients less than 50 years of age. However, in patients more than 50 years of age, there was no significant difference in patients who received chemotherapy. So the conclusion was that yes, this assay gives us confidence in avoiding chemotherapy in patients above 50 years of age with a low genomic risk profile. And the potential benefit of chemotherapy is to be discussed in patients who are younger, and we don't know why this benefit is there. It is the possibilities are either younger patients respond better to chemo, but then it's not likely to show so late, and the second is it is related to chemotherapy induced ovarian suppression, which also we have seen in multiple other trials, including TAILORx data and SOFT. So we should consider chemo in patients less than 50 years after discussion. The limitations of this were, as we all know, that taxanes were not included, adjuvant online is no longer available, and we have better predictors of clinical risk. However, the biggest limitation is how many patients of ours do end up getting MammaPrint or can afford MammaPrint. So moving on to the next abstract, this was presented in ASCO 2021, and this is again on the MINDAC trial. They studied the outcome of patients with an ultra low risk signature. So about 15% of patients in MINDAC trial had genomic ultra low risk, and in historic cohorts, these patients are known to have an excellent survival. So they had studied the outcome of patients with this biology, and the objective was that, can we identify patients with ultra low risk and help to avoid overtreatment in early breast cancer? And yes, it showed very promising results, because about 1,000 patients with ultra low risk more than 50 years were almost 67%. Most of them were T1, N0, grade 1, grade 2, and 99% were ER positive. About 70% of them received only endocrine therapy, 14% received combination, and 6% received no systemic therapy. As you can see, excellent 8-year distant metastasis free interval, and breast cancer survival, BCSS. So almost 99.6, that's like 100%. So it proves that ultra low risk gene signature almost represents an indolent disease which will do extremely well with endocrine therapy, and chemotherapy can be safely foregone in these patients. The third abstract, again based on MammaPrint, is utility of this assay to decide patients who will benefit from extended letrozole therapy. As we know, the NSABP B42 trial studied the benefit of extended letrozole in patients who were disease free at 5 years after AI of 5 years, or tamoxifen less than 3 switch to AI to complete 5 years. These included patients with stage 1, stage 2, stage 3A ERPR positive breast cancer, and all were postmenopausal. So these patients were stratified based on nodal status, tamoxifen, and bone health, and then they were randomized to either receive letrozole for 5 more years or placebo. And this was a trial which did not show significant difference in the overall survival with extended letrozole therapy, but it showed 3.3% improvement in DFS, and also reduction in breast cancer free interval, and distant recurrence rates were also lower. So all the patients whose blocks were available from this trial from B42 were, the blocks were collected, MP scores were generated, the results were merged with the clinical data, and 10 years follow-up was done. We had about 1800 of patients, of which MP low risk was 62%, and 22% of these were ultra low risk. And if you see this table, all the patients in low risk had improved distant recurrence, DFS, and BCFI, significant improvement with extended therapy. So MammaPrint low risk benefits with extended letrozole therapy, whereas the high risk did not have that many benefits. Again, in the low risk, when they stratified between ultra low risk and low but not ultra low risk, surprisingly, the difference was more, the benefit was more in non-ultra low risk, because ultra low risk is an indolent population which derives maximum benefit with 5 years, and extending it does not improve the benefit. So that's the take home from this. So we definitely have a significant benefit with ELT in MP low patients. But we need more trials to confirm this. The next MammaPrint study was again, seen effect of 20 years of endocrine therapy in premenopausal patients. These patients are at higher risk of fatal disease. We know that. So a study which was done in 1990 to 1997 in Stockholm, where patients were randomized, stratified between lymph node positive, negative. Positive ones received chemotherapy. Negative ones were then again randomized, and after chemotherapy also the positive ones were randomized into 4 groups. One group received goserelin, one received tamoxifen, the other received a combination of both, and the fourth received no adjuvant treatment, no systemic endocrine therapy. So blocks from these patients, about 729 patients were taken. ER positive was 610, and then the risk was assessed from MammaPrint, and then the treatment that was given was analyzed, and as expected, any form of ovarian suppression or tamoxifen showed more benefit than no endocrine therapy. However, the patients with high risk showed more benefit, the hazard ratio of 0.33, with the combination of with just goserelin instead of the combination, and patients with low risk showed more benefit with tamoxifen alone. So this is to be kept in mind. Probably again, it is why chemo benefits high risk patients, because of ovarian suppression. So goserelin helps in that. That could be a possible explanation. However, it's not practice changing for us at the current point of time, but it's good to know that this data was analyzed. So coming to the more important studies, which were tools that were developed to get better idea besides the risk score. So this study published in NEJM was on TAILOR-X or Oncotype DX risk score. We know that TAILOR-X did not include patients with positive lymph node disease. So there was this hypothesis built that with hormone receptor positive, HER2 negative N1 disease in patients with recurrence score less than 25, absolute risk of recurrence should increase with higher scores, and the relative benefit of chemotherapy should also increase with higher scores. So this study included this subset. Almost 5,000 patients were included, and they were stratified based on the risk score and the menopausal status and the axillary surgery. The primary endpoint was IDFS. Mind you, just recurrence score 0 to 25 were included in this patient in this study, and they were randomized to either receive only endocrine therapy or endocrine therapy with chemotherapy. Secondary endpoints were multiple. As expected, postmenopausal women did not show any benefit in the IDFS or in the OS, of chemotherapy. Premenopausal women, however, IDFS, there was almost 5.2% of absolute difference in the IDFS with chemotherapy. Overall survival, absolute difference was just 1.3. It was not statistically significant. Now, when this was divided according to the risk scores, both the risk scores, be it 0 to 13 or 14 to 25, postmenopausal women did not benefit. Premenopausal women, both the risk scores had constant benefit. 0 to 13 had about 3.9%, and 14 to 25 had about 6.2% of benefit. If you see the forest plot, all the patients of postmenopausal women across all the subtypes had benefit with ET, whereas premenopausal, most subgroups had benefit with chemotherapy. So we know that chemotherapy among, in premenopausal women can benefit patients. However, it does not really increase with the risk score. And the reason for the benefit is less likely to be because chemo is more effective in these women, but more likely because of ovarian function suppression, as we have discussed earlier. So this needs some more thought, but chemo still is a part of the suggestion in these patients who are premenopausal. Postmenopausal women, we can easily forego chemotherapy. This is an excellent chart which shows that no postmenopausal women less than risk score of 26 should receive chemotherapy. This is premenopausal, but the second chart. But in premenopausal, again, high clinical risk has more advantage. In lymph node positive also, you need to discuss in those less than 25. Now, there was this another tool. This is where clinical and pathological factors along with the risk score were combined to form a tool. It called RS Clean. RS Clean was a tool that integrates clinico-pathological as well as risk scores. So in this, the prognostic factor was used from B14 data and TAILORx trial, and the predictive factor was used from B20 and TAILORx trial. And almost 10,000 patients were used in this, analysis. And externally, these prognostic scores were validated from an Israel cohort called Claret Registry, and it showed that this kind of a scoring system, which combines both clinico-pathological as well as RS, is better than RS alone. I won't go into this. You can see these two charts. On the left side is low risk patient, right side is high risk patient. Y-axis, absolute benefit of chemotherapy, and x-axis is the gene recurrence score. So in the low risk patients, you can see the blue line. The benefit of chemo only starts increasing after 20, and there is a steep rise. Whereas in high risk, the curve is steep from the beginning. So, and the constant relative, the blue one is where both the clinico-pathological and the risk score are being integrated, a proportion. So there is a constant relative CT effect, higher risk score associated with higher risk of recurrence, but not greater relative CT effect. So the recurrence risk increases, but the chemotherapy per se is not improving the prognosis as such. That has to be kept in mind. Another tool, the kinds which, so this is the last tool where we don't even need the assays to determine the risk. So this is an excellent tool which was built based on simulation. It was published in JCO, where almost 1,500 simulations of unique patient types based on their age, tumor size, grade, comorbidity level, with or without 21 gene recurrence scores were used. Model inputs were derived from patients from very good trials and good registries, and then they were analyzed, and then there were separate subtypes made, and simulations of their KM curves were prepared, and the ultimate report showed life years gained, estimated by calculating the difference in average life years from chemoendocrine therapy versus endocrine therapy for each subgroup. So just as an example, if there is a woman of 65 to 69-year-old with T1 lesion, intermediate grade, no mild comorbidities, the risk reduction was 1.3% in distant recurrence. Okay. Now, if this lady, they could even predict what was the probability of having which risk score. So if the risk score was between 16 to 20, the benefit that she would get because of chemotherapy, number of life years gained would be 0.2, and the distant recurrence risk would be 1%. Whereas if the recurrence score comes to 26 plus, then the benefit would be 4.8 to 5.5%. So in patients where the score is available, also this tool can be used, whereas you could also apply it to patients where it was not available. So this is a good tool, and it is a flexible tool. They are still adding, it is currently available only for lymph node negative. They are still adding types, subtypes, risk factors to this, and in the future it will be available, and I think it will be a great tool for people who cannot afford recurrence scores. Coming to the last one, it is though this was the first paper in 2021 in JAMA Oncology, I'm presenting it last. It's just to emphasize that there is a lot of racial and ethnicity difference when you use these recurrence score. So this study was done to examine the breast cancer specific mortality across different races and ethnicity, and mainly it was a retrospective study, and mainly it was done for seeing the outcomes in Black women. You can see they were only represented as 8% of the population, and it is quite shocking that in all recurrence score subtypes 0 to 10, 11 to 25, more than 25, breast cancer specific mortality is hugely higher in Black women, be it in node negative disease or node positive disease. So we do need to understand that Black women have high risk, disproportionately aggressive ER tumors, and more than that, genomic prognostic assays may require recalibration for racial and ethnic minority groups. So we are hardly represented in any of these trials. Caucasians data cannot be used to interpret how we are going to behave to these genomic signatures. We need to have our own data. So in the era of de-escalation and absence of reliable economic risk assessment assays in our country for patients in gray zones, we do tend to err towards over treatment instead of under treatment, but this needs to change. We need to have genomic risk assays, especially for our population. There are a few upcoming, I don't want to name them, but we need more data, more confidence to start using these assays, or the online tools which are not industry dependent. We should have more access to it. Thank you.